Ja, herzlich willkommen. Ja, mein Name ist Thorsten Zenz, and I will switch to English because we have some English guests. So it's a great pleasure to welcome you all. So we've Silke and the others have restructured our teaching and our Fortbildungs scheme. So now the major org disease areas get afternoons like the one that we have today. So it's a great pleasure for me to welcome you. So this is what I just introduced. So we cover all sorts of disease areas. We also have on the bottom some longer symposia, and obviously you're all very welcome to take note and join us. Alexandra is listening. We also have a lot of activities with our patients. So that's shown here. So these are just the patient events for November, but there's also annual survivors days, which are always a huge success. And yes, these activities are supported by many pharmaceutical companies, as you can see from this slide, and the Comprehensive Cancer Center is very grateful for the support. So that's the introduction. So it was a great pleasure for Rouven Müller and myself to organize the day. So we picked two important disease areas in I guess the center is called leukemia, lymphoma, myeloma. And you can see the program there. I won't take more of the time, but I think it'll be nice to see. We will present some of the USZ speakers. The Zurich speakers will present what they think should be done, but we also have knowledgeable people from outside, like Ulrich Mey from Switzerland and Jessica Ikosun from London and Francesco Annibale from Aarhus. So we will get started, and I will hand it over to Rouven, who will chair the myeloma part. I asked the chairs to be strict on the time for the actual presentation, but we can be more flexible with the actual discussion, which we should have some time for discussion. And then the second part, Nadia Jabi and myself will chair. So thanks for coming, Rouven.
Yeah, thanks, Thorsten. Welcome also from my side. My name is Rouven Müller. I'm working here at the University Hospital. I'm happy to chair this myeloma session. We have 3 talks. Actually, Ulrich Mey from CUR will start with the first-line treatment. He will discuss guidelines and open questions. Then Cosima Suter from our department will take over with a very interesting case of a patient that was treated in our hospital. And I will finish the myeloma session with a talk about CAR-T and bispecifics in multiple myeloma. I would like to quickly introduce Uli. Hello, welcome. Ulrich Mey trained medicine in Bonn at the University of Bonn. He also spent his residency there in internal medicine, hematology, and oncology. I think in 2007 you got the Venia Legendi. In 2009 you migrated to Switzerland, to CUR. Actually, you're working in CUR first as a leitender arzt, and I think since this year as head of the hematology subdivision at the Kantonsspital in Graubünden. I'm very happy that you accepted the invitation, and we look forward to your talk, Uli.
Yes, thank you very much for the kind invitation. Dass ich das als Pointer bekomme, statt als Pfeil? Okay. Thank you very much for the kind introduction and for the invitation to give this talk on the first-line treatment in multiple myeloma. When Dr. Müller and I agreed upon the topic of this talk. We were very confident that the updated Swiss recommendations on the treatment of myeloma will long be published, as they had been accepted already in May 2025. And it's more than regrettable that they are still not available online. So in the meantime, the international EHA-EMN guidelines have been published by Dr. Dimopoulos, and these will serve as the basis for my presentation. Let's literally warm up with smoldering multiple myeloma. You know, this is the condition where we have an increased percentage of plasma cells in the bone marrow or increased paraprotein levels, but not yet myeloma-defining events as defined by this so-called slim crack criteria that had been published 11 years ago in this IMWG paper and that are still valid. Now, everybody of you knows that the risk of progression is much higher for patients with smoldering myeloma than for MGUS patients, particularly during the first years after diagnosis. And we now have a very good and easy to use model to stratify patients according to their risk, just using the serum M protein level, the kappa lambda ratio, and the bone marrow plasma cell percentage, the so-called 20-20 rule. And patients can be divided into high risk, low risk, and intermediate risk. Now, there was a very ambitious study made in Iceland, and they asked the whole population older than 40 years of age to participate in this survey. And actually more than 50% of the people did. And from this large study, we now know that the prevalence of smoldering myeloma is more than 0.5% in the healthy population. This is higher than initially assumed. We know that men have a higher risk, and it increases with age. And about 1/3 of patients have a non-low risk situation. Although the observation is still considered the standard of care for this patient, there were earlier trials that showed that lenalidomide-based treatment is able to prolong progression to multiple myeloma, and even of more importance, in the Spanish trial, there was even an overall survival benefit for early treatment of these patients. I just want to show you one important newer trial that was presented at last ASH by Dr. Dimopoulos, the so-called Aquila trial. In this trial, patients with high-risk smoldering multiple myeloma were randomized to either active monitoring, the current standard, or to daratumumab monotherapy for 3 years. And although the criteria used to define high-risk smoldering myeloma are not the same as the 20-20 rule because it was developed later, a retrospective analysis using the new modern criteria could show that there's a huge difference with regard to progression-free survival in favor of daratumumab treatment. And even more important, in this trial, there was also an overall survival benefit for the treated population. One caveat, when we look at the data, we see that only a quite small proportion of patients actually received anti-CD38 treatment when the disease progressed to myeloma. So this limits the applicability to today's landscape. The guidelines today, 2025, recommend to use the risk assessment according to this 20-20 rule. They recommend not to treat patients with low or intermediate risk, and they say that you can consider to use daratumumab as a monotherapy, although not reimbursed at the moment. And the best thing always is to enroll patients in clinical trials. Now let's go to treatment of multiple myeloma. And still, most large trials stratify patients according to their eligibility for high-dose chemotherapy and autologous transplantation into fit and unfit patients. And we start with the younger transplant-eligible patients. Here you can see the differences between the last version of the EHA-ESMO guidelines and the new one. Whereas the Cassiopeia DARA VTD or just VRD were also recommended in the last version. Now, for virtually every patient, a quadruplet regimen, either with daratumumab or isatuximab, is recommended for all newly diagnosed patients. And there's the second big difference. We don't use only lenalidomide maintenance therapy, but according to the very good results from the Perseus trial, we also use daratumumab. Now, you all know these trials, and you all know the favorite names of these trials: Andromeda, Perseus, Cassiopeia. I think everybody of you knows, but I'm not sure whether everybody of you knows who Perseus and Andromeda and Cassiopeia really were. And please allow me just a few minutes on this. So Perseus was the king of Ethiopia, and he was married to Cassiopeia. They had a daughter, beautiful Andromeda, who later married Perseus. So he is the son-in-law of Perseus and Cassiopeia. Now, trouble began when Cassiopeia, who was known for her vanity, Eitelkeit, she boasted that she herself, and in some versions her daughter, was more beautiful than the Nereids, the Meernymphen. Well, this is a heavy statement, as you can see on this slide. And the Nereids were so upset, that was so outrageous, that they went to Poseidon and they complained about what they heard. And so Poseidon completely understood and he sympathized with them. And so he said, let's punish the couple, the royal couple. And he sent a monster called Ketos, and to destroy the coast of Ethiopia. And so Cepheus went to the oracle and asked, what can I do to stop this monster destroying my country? And the oracle said, there's only one way. You have to sacrifice your own daughter, Andromeda, to the monster, and then it will stop. And this is where Perseus comes into play here, because when he came home after fighting against Medusa, he saw beautiful Andromeda chained to the rock and fell in love immediately. But before he rescued her, he talked to her parents, and he said, well, I will rescue your daughter, but then I want to marry her. They agreed upon that, and that's how it came. And you see here Cepheus and Cassiopeia together with Perseus after he rescued her, and then they were married. So now you maybe see Perseus as a different part here. We have this trial comparing VRD treatment in younger patients to daratumumab and VRD. All patients received transplant and consolidation, and of note, all patients who initially, during induction, received daratumumab went on to receive daratumumab during maintenance. There was no second randomization for at least 2 years, and they could stop the treatment if they were 12 months MRD negative, so sustained MRD negativity. And you all know the data, the results of these trials. There was a highly statistically significant and clinically relevant advantage for the quadruplet versus the triplet. And all patients who received MRD negativity to this high threshold had a very good prognosis, irrespective whether they had daratumumab or not. But of course, the proportion of patients who were MRD negative was much higher with the quadruplet. And you can see that about twice as many patients achieved MRD negativity with the quadruplet. Now, there was a very provocative slide shown by Dr. Sonnefeld at the last EMN meeting earlier this year, where his statisticians calculated the estimated PFS for the Perseus trial. And they calculated it would be something around 17.1 years. And even without transplant, they estimate more than 8 years of progression-free survival, thereby defining this as a new treatment and standard of care. The second important trial that you have to know is the so-called GMMG HD7 trial. In this trial, VRD was compared to isatuximab, the other CD38 antibody, plus RVD. And the main difference between the Perseus trial is that there was a second randomization after induction and autologous transplant, where patients again were randomized to either get the antibody or not. So when the data will come available from this study, we can better define what is the role of continued anti-CD38 treatment in the consolidation phase. Again, this trial showed an impressive PSS advantage, and also MRD status was much better with the quadruplet as opposed to the triplet. And also these curves look virtually the same as in the Perseus trial. Very good results with MRD negative patients. And if they're still positive, then those patients who receive the antibody do better. And the third important trial that you should look at for this patient population is the so-called MIDAS trial from France. It was presented at ASCO and published in the New England Journal of Medicine. All patients received again the antibody isatuximab together with a more intensive induction regimen, KRD. So this is carfilzomib instead of bortezomib. And then patients were randomized according to their MRD status after induction and after autologous transplant, after induction. And if they were already MRD negative at the level of 10 to the minus 5, they were randomized to either receive the standard autologous transplant or to skip autologous transplantation and just to give the consolidation with ISA-KRD. Opposite, if they have if they're still MRD positive, then they were randomized between single or tandem autologous transplant. And of note, almost 2/3 of patients were MRD negative at the level of 10 to the minus 5 after the induction. And here you can see the results. Those patients who already were MRD negative did not improve with autologous transplant as compared to ISA-KRD only. And those patients who were still positive did not achieve better MRD results after tandem autologous transplant compared to single transplant, further questioning the role of double transplant in the era of quadruplet therapy. But if you look closer in the subgroup analysis, you see that patients with a high risk, high cytogenetic risk, or those who are not at the deepest level of MRD negativity might be those who still benefit from the autologous transplant. And in the future, we will see, I don't have the time to go through this, we will see whether bispecific antibodies like elranatamab or teclistamab, or even CAR-T like cilta-cel as a consolidation might further improve the already very good results of our patients. So now switch to transplant ineligible patients. Here again, the differences between the older and the new guidelines. And already in the older guidelines, DARA-RD, the Maya regimen, was the recommended first-line treatment. This is still also the case today. But now also for older patients, we have 2 quadruplets, either isatuximab or daratumumab, that are recommended as first-line option. These are the 4 key trials that had been done in the past for older patients. We have the older Alcyone trial with Dara-VMP, not commonly used today. We have the famous Maya trial with DRD. We have the SWOG trial showing that RVD is better than RD, and a very small trial, just 50 patients, but which is clinically relevant because it gives us the opportunity to give an RVD light regimen. And I will only show you the data of the Maya trial because this has become something like a one-size-fits-all for every patient, every older patient that is not transplant eligible in the last years, where daratumumab was added to the former standard of RD. And you all know the results. There's a clinically significant PFS advantage for the 3-drug regimen with the antibody, with more than 5 years of progression-free survival in this older patient population. And there's a robust overall survival benefit as well, and therefore it was the standard of care. Now, at last ASCO, Professor Facon showed the results of the so-called IMROS trial. IMROS added isatuximab to VRD and compared it to VRD. Of note, in this trial, bortezomib was given on the 1-4-8-11 day regimen, as we had done previously, but this is not commonly applied to older patients today. And also dexamethasone was given twice 2 days in a row, so quite high doses of dexamethasone in this trial. And patients had to be younger than 80 years, that was by definition, and therefore only about only a small portion, about 10% of patients had a poor eco-performance status. So this was a very fit older patient population. And you can see the results. There was a statistically significant and again clinically relevant PFS advantage for the quadruplet as opposed to VRD only, with more than 60% 5-year progression-free survival rate. And again, the responses and particularly the MRD negativity rate was much better with the quadruplet as expected. Overall survival is still not mature, but you can already see a trend for the quadruplet. And as expected, neutropenia was more common with the daratumumab antibody, and so was pneumonia. There were more infections in the quadruplet arm. A post-hoc analysis of this trial was done by Professor Mey, and he looked whether around 40% of patients in this trial were considered frail. And he looked whether frail patients did benefit from this treatment. And as you can see, the dashed line are the frail patients. Still, those patients benefit from the 4-drug regimen, but their overall prognosis is worse than those patients who are considered not frail or fit. I think even more interesting or even more important is the so-called benefit trial, which was simultaneously presented at ASCO by Professor Leleu. And in this trial, again, isatuximab plus RVD was compared, but this time against isatuximab RD, so the Maya regimen pendant with isatuximab, and challenging the role of adding bortezomib. And very interesting is that bortezomib was only given once weekly. So like a regimen that we all do in our clinical practice for older patients. And also dexamethasone was only given once weekly, and after 1 year, it was omitted completely. So much more like we would like to do it for this patient population. Around 1/3 of patients were older than 75 years of age. And again, a big difference in MRD negativity for the 4-drug regimen. The survival rates are not mature yet. The follow-up of this trial is much shorter than the other trial I had shown you. And the last one that we should mention is the so-called Cepheus, published a couple of weeks later, where VRD was compared to subcutaneous daratumumab, which makes it also a very attractive regimen. But again, bortezomib in this regimen was given on day 1, 4, 8, and 11. And by definition, all patients must not be frail, so they were not enrolled in this trial. And you can see, again, MRD negativity rates much better with the 4-drug regimen, and also the response rates. And particularly the sustained MRD negativity rate was almost twice as high in the quadruplet arm. And again, a large PFS advantage for the quadruplet, making this also a new standard of care. So the paradigm had been that all patients who are not transplant eligible should receive something like Maya regimen, DARA-RD. And now, today, we would say that fit patients should even receive more, namely one of the 4-drug regimens. And the question is, should we give less treatment, is less more for the frail ones? And the idea came from a subgroup analysis from the so-called Maya trial. Again, we see that also the Maya patients, the frail Maya patients, did benefit from the addition of the antibody. But of note, this continuation rate in the first year of treatment was much higher for the frail patients than for fit or intermediate fit patients. And even more important, the incidence rate of severe adverse events, and particularly of the death rate, was much higher for the frail patients. And in this regard, this trial is very important. That was shown again by Dr. Mey at last ASH meeting, where RD, lenalidomide dexamethasone, was compared to daratumumab and lenalidomide, omitting dexamethasone. It was just given during the first 2 cycles and then completely omitted. So dexamethasone sparing regimen. And this trial was only developed for frail patients by definition. So all patients had a frailty index of at least 2. And you see that 60% of patients were older than 80 years of age. And in this trial, the DARA, lenalidomide arm was much better, not only for progression-free survival than the former standard RD, but also for overall survival, thus defining a new standard of care for this patient population with a hazard ratio of 0.52. And this is the most important part of this trial. You can see that the death rate in this trial was equal in both treatment arms. There was more neutropenia with the antibody, but the infection rate was the same. And the discontinuation rate in this study was also the same in both treatment arms. So today, we would say the fit patient who's not eligible for transplant should receive a quadruplet, and the frail patients could receive a dexamethasone-sparing treatment like RD. And the future will tell us whether bispecifics or treatment-free intervals or MRD-guided treatment might have a role in these patient population. This is my last slide and summarizes everything that I have shown you. So the fit patients, transplant eligible, should receive the quadruplet and go on for transplantation. If in doubt, or those patients who are not fit, not eligible for transplant but fit enough, they also should receive a drug regimen, and then you can decide according to risk or MRD status. And the frail patient, you have the option to omit the dexamethasone and just give daratumumab and lenalidomide. And with this, I would like to thank you for your attention.
Yeah, thank you, Ulrich, for this excellent talk. Other questions? Sebastian?
So you showed the data regarding an MRD-driven approach. So what is your approach to elderly patients regarding an autologous stem cell transplantation, high-dose intensification?
For elderly patients?
Yes.
Yes, so this would be, so if they're not eligible, then there's no question that you can't do it. But there is this doubtful patient population where you might think it may be possible, but it's a little bit difficult. And then you could decide on MRD negativity. So if you reach MRD negativity after induction, it might not be so important to have the risk of transplantation. But if the patient still is MRD positive and you can try the autologous transplant, I think then this could help.
But that's your standard approach.
Yes. To be honest, we don't have so many patients yet of the elderly population who had the quadruplet regimen, but I think that this is the way that we would decide.
So the doubtful patients are perfectly fitting for the quadruplet in the elderly population. Mm-hmm. Do you think we are doing transplant in 10 years?
I think it will be less. We talked about the tandem transplant, and in our new recommendations, we still have it in there. We say if the patient is still not in best remission and the first transplant was without any problems, then you might consider this. But I think today with the MIDAS data, so double transplant will rarely only be used. And also single transplant, the trials that we have without quadruplets, without the antibody, have also not shown an overall survival anymore. But there's a huge PFS advantage, so still there is the recommendation to do this. But I could imagine that with bispecific antibodies, for example, that we could get rid of the autologous transplant in the future.
Yeah, the DSMM is doing a trial in the induction, yes. Do we have questions in the chat? Or?
Yeah, Uli, so you didn't mention the risk, the genetic risk. So is there any variation of the themes you so nicely presented based on 17p or 1q gain or some of the other alterations in first line?
You have seen there is now a new risk stratification that has been published recently in the JCO. It redefined the high-risk situation, and it does not really play a role for the treatment that I had shown. But for the high-risk patients who are around 20% of all myeloma patients, we know that even with quadruplets and even with autologous transplant, the results might not be optimal in this patient population. And we might improve maybe with more intensive approaches like bispecifics or KRD or whatsoever.
Okay, we are perfect in time. I would like to thank Ulrich Mey for this excellent overview, and I would like to invite Cosima Suter from our department to the stage. She will present a very interesting case, patient case showing the different treatment availabilities in multiple myeloma. Thank you, Cosima.
Thank you, Rouven. Yeah, it is my pleasure to present the case of Mr. T this afternoon, and this case nicely illustrates the evolution of the myeloma treatment landscape over the past decade in Switzerland. So we first saw Mr. T back in 2015, and he had been suffering for low back pain for the past 3 months, possibly after a sudden movement at work, but reported no major trauma. He didn't have any neurological deficits. He was a healthy 55-year-old man, had a somewhat high cholesterol and a higher body weight, but other than that, healthy. His GP had already ordered an MRI, and there we found multiple fractures of the lumbar spine and an altered bone marrow signal. In our diagnostic workup, we saw anemia with a hemoglobin of around 100 grams per liter, a monoclonal IgG copper, and an M spike of 28 grams per liter. And in the bone marrow, we saw 60 to 70% plasma cells, and FISH revealed a high-risk cytogenetic profile with a deletion 17p and a gain of 1q. We started treatment with VCD, which was our standard back in 2015, and induction was followed by 2 rounds of high-dose chemotherapy with melphalan, followed by autologous stem cell transplantation, after which he reached a VGPR. We then proceeded with maintenance therapy, initially with bortezomib, and due to grade 3 neuropathy, we then had to switch to ixazomib. And his response actually further deepened during maintenance therapy when he reached the CR. In 2020, so almost 5 years after initial treatments, he eventually progressed. And we then initiated second-line treatment with DARA-RD. We now saw a somewhat different patient. He was obviously 5 years older, but he had additional comorbidities. So he had developed a diabetes type 2, which required insulin on the dexamethasone days. He had chronic kidney disease, stage 3, and he also had a provoked proximal deep vein thrombosis, and we kept him on prophylactic DOAC due to active myeloma. But essentially, we were treating a patient in second line who was daratumumab and lenalidomide naive. And this is a bit different from the patient population we saw in Pollux, where the majority of patients had actually already seen lenalidomide. Treatment with DARA-RD was well tolerated. We did see intermittent neutropenia, grade 3, and this is also very well known from the Pollux population, where 52% of the patients had grade 3 or higher neutropenia, and we intermittently used GCSF. He did have a couple of respiratory or abdominal infections per year, but the most significant infection for him was a portacat infection with an ESBL Klebsiella in 2023. Fortunately, we saw really good treatment response, and only after 2.5 years, the M spike suddenly and slowly started to increase, but progression could actually only be documented after around 44 months at the time when he developed new vertebral fractures, but also fulfilled the criteria for biochemical progression. And in a high-risk patient, we would actually expect a PFS of only 27 months if we look at the Pollux population. So in a way, he was behaving more like a standard risk myeloma patient in the second-line treatment. When he then progressed at the end of 2023, we chose to initiate a third-line treatment with KPD. He was then 64 years old, still had the same comorbidities, so thankfully no new complications. And because he did have a considerable cardiovascular risk profile, he underwent regular cardiac assessments. And we had a normal echo at the beginning of KPD, and then also 3 months into the treatment. At the end of 2024, unfortunately, he developed a self-limiting episode of chest pain at rest, and troponin was significantly increased with 429 nanograms per liter, and we diagnosed him with a non-STEMI. He then obviously underwent coronary angiography, and we saw a coronary 3 vessel disease, and he did have to undergo coronary artery bypass operation after a couple of days. And thank God he recovered impressively swiftly from this large operation. So we all know that carfilzomib and also to some extent bortezomib are associated with cardiovascular complications. And I would like to take a short amount of time to actually look at the data and what the guidelines say. So around 50%, so half of our myeloma patients have established cardiovascular disease. And carfilzomib and also to some degree bortezomib are associated with cardiovascular adverse events, mostly hypertension, and then in roughly 4% of the patients, heart failure, and 2% develop ischemia. And in 2019, a group actually looked prospectively at PI-treated patients, and those participants underwent serial measurements of cardiac biomarkers, of ECGs and echoes. And they actually found that half of the carfilzomib patients developed on-treatment cardiovascular adverse events, and this was particularly in the first 3 months of therapy. And 6% of all patients had ACS just as Mr. T. In a couple of years ago, there were also some guidelines published by the European Myeloma Network in collaboration with the Italian Arterial Hypertension Society. And they tell us that we should be screening our carfilzomib patients for cardiovascular risk factors at baseline. They should have an ECG, they should have blood pressure measurements, and they should undergo an echo. Obviously, if we find risk factors, we should treat them and we should monitor them. And if they then develop grade 3 to 4 adverse events, which we believe to be related to carfilzomib, we should either interrupt treatment indefinitely or reduce the dose. Now, in our patient, the situation was pretty clear. A, he had a major cardiovascular event, and B, he was also progressing on third-line therapy, so we needed to start another treatment line. And having a pentarefractory disease, so being refractory to an anti-CD38, to 2 IMiDs and 2 PIs, he now clearly qualified for CAR T-cell therapy. And to bridge the time for lymphopoiesis and cell-to-cell production, we initiated treatment with a BiTE and obviously chose the other target, so not BCMA like cell-to-cell, but we then went for GPRC5D and exposed him to talquetamab. He swiftly responded to talquetamab, and he reached a VGPR within 10 weeks. The side effects were minor, so he had a bit more xeroderma, some minor nail changes, but treatment was really well tolerated. And the response we saw was actually very much in line with what we expect from the published data. After 5.5 months, we then chose to proceed to CAR T-cell therapy, and he actually received his CAR T-cells 3 weeks ago. He tolerated it very, very well, didn't develop any CRS or ICANS, and he could be discharged after 10 days. And he was very excited to finally have the CAR T-cells, and obviously he and we are very hopeful for this treatment. So I'd like to thank Mr. T for giving his consent to presenting his case today and entrusting us with his care, and thank you for your attention.
Yeah, thanks Cosima for this interesting case. Other questions? Marcus?
Yes, so it's a very nice case to show here with subsequent successes of all the new exciting developments. What I was wondering is towards the question on what is the right timing for CAR T-cell therapy. In this case, you chose to do it upon a very good response with bispecific. And it's not clear to me if this is the right thing to do or whether he should have enjoyed more time on this therapy until going to CAR T-cell therapy. So what were the considerations in this patient, but maybe also more in general, what are the thoughts of you, of course also Rouven, others that participate here, how should that be managed?
So thank you for the question. Obviously, we, as you pointed out, we don't know the ideal time point. What we wanted to reach is a really good response to talquetamab. And quite frankly, for Mr. T, CAR T cells were in a way the holy grail. So this was like the end goal, and also the therapy he believed that would give him the most benefit. And he actually also asked us to then proceed to CAR T cells rather swiftly. And since we saw a really nice response on talquetamab, and we know that the response to talquetamab is limited, that is why we made this decision to give the CAR T cells after 5.5 months. We could also have done it after 4 months or after 8 months. We really don't know. It felt like the ideal time.
I will also try to elaborate on this important question in my talk, that we should start now. Thanks a lot, Cosima, in the interest of time. So I have to click here, I think, on the button. So I will finish this session with a talk about CAR T-cell therapy and bispecific antibodies in multiple myeloma. These are my topics. After a short intro and some words about the prognosis in later lines of therapy, I will go through the available targets at the moment for T-cell redirecting therapies. We'll talk about the pivotal trials and real-world evidence in CAR T-cell therapy and bispecific antibodies. Sequencing is an important topic. We will come to, and in the end, if we have some time left, some practical considerations and some words about supportive care. So let's start. What we have in multiple myelomas, this is a list of FDA-approved drugs. So in the last 25 years, a huge amount of substances were approved. And even 10 years ago, this is a picture from a a slide in Milan 10 years ago, where daratumumab and CD38 treatment was in every editorial. And in a review from that time, in Leukemia 2015, BCMA was a potential new target. So today we use BCMA basically in these, it's a standard in bispecifics and CAR T-cell therapy. So this also shows the huge progress in these 10 years, in these 10 years that has been made. I will focus on these 5 already also in Switzerland approved drugs, so ide-cel, cilta-cel, the BCMA CAR-Ts, and teclistamab, elranatamab, the BCMA bispecifics, and talquetamab is the so far only approved GPRC5D bispecific antibody. We have a huge, I have to say more, we had a huge medical need in these triple-class exposed multiple myeloma patients. This is data from a retrospective cohort from the US, from the SEER database, showing this very dismal prognosis of patients that were refractory to CD38 with a median OS between 5 to 12 months, depending on the additional refractoriness to PIs and IMiD. And this was also investigated prospectively by the Spanish group in the locomotion trial, with similar results, a median PFS of 5 months, a median OS of roughly a year. And we have to be aware that we lose, with every line of therapy, we lose patients. And we also have reduced treatment-free intervals and reduced duration of response. A strong argument for using the most efficient therapies first in this disease, and not to save something for later lines. We have to reduce the disease burden to avoid clonal evolution, to avoid further clones that harm the patient. These are the basically 3 interesting myeloma. There are a lot of more myeloma target antigens that are currently exploited in bispecific and CAR T-cell treatment. The BCMA is a member of the TNF receptor superfamily, actually TNF receptor superfamily 17. It has a critical role in differentiation of the normal B-cell compartment to plasma cells. It's highly expressed on the myeloma cells for sure. It's also expressed on the B-cell lineage in the normal plasma cells. Very important target we use. The GPRC5D, this is an orphan receptor. We do not know the ligand. Its expression level is significantly higher on multiple myeloma cells compared to normal plasma cells, but unfortunately it's also expressed on other tissues. The skin, the nail, keratinized tissues are expressing GPRC5D. It's also expressed on the tongue, and targeting GPRC5D can cause off-target side effects like dysphagia and loss of taste. This is just graphically shown when BCMA is expressed, starting on the germinal center B cell and highly expressed on the long-lived plasma cells and multiple myeloma cells. It is shedded from the surface by a gamma secretase, and there were some trials around that tried to avoid this to keep the antigen target in its place. GPRC5D is expressed here in the bone marrow in a high amount, and here you see in the skin, sun and not sun exposed, and also in the tumor cell lines, in the multiple myeloma cell lines, it has been deciphered, and its expression is increased depending on the, let's say, malignant state of the plasma cell dyscrasia, from normal to MGUS, smoldering myeloma, and multiple myeloma expression is increasing. Another, a little bit more new and not so well tested yet target is FcRH5. This is a slide from EHA where a trial exploiting cevostamab was presented. FcRH5 is also expressed exclusively on the B-cell lineage. And cevostamab, we'll come to that later, tries to target this, redirecting the T cells to the myeloma cells. There were some promising primary results in the phase 1 trials. So we all know these CAR T cell cycle with the apheresis of the T cells, the expansion of the T cells, the genetic modification, the introduction of the CAR. Then back on site with the product, the lymphodepletion and reinfusion of the T cells, and then surveillance of the patient. And these are the first trials, the pivotal trials of the ide-cel construct. So with the murine CAR, the KarMMa-1 phase 2 trial showed nice responses up to 80% in the high CD, in the high CAR T cell cohort. But unfortunately, this was not a very long-lasting effect. The PFS in total 8.8 months, up to 12 months only in the 450 million group. So this was a little bit sad in the end after seeing these high response rates. In the phase 3 KarMMa-3 trial compared this against the to that time standard of care, so a mixture of physician's choice protocols, DPD, DVD, ixazomib was included, carfilzomib dex, and elopom dex, and there the PFS of roughly 1 year was confirmed, but this not in that extent that we were really happy with it, with such an intensive and also economically intensive treatment. The standard arm has something similar like in the locomotion trial that shows that these patients had an efficient standard of care arm. This changed with cilta-cel, the CARTITUDE-1 trial, the phase 1 trial. It came out of the LEGEND trial in China. This construct has 2 binding domains. These are from camelid origin, fused to 4-1BB and CD3 zeta, and actually tremendous overall response of 98% and very deep responses, stringent CRs of 82.5%. And this trial showed a median PFS of nearly 3 years. Overall survival was not reached to that time point of 3 years follow-up. Going back here to the KarMMa data, this is a huge advance. We saw here a median PFS of 10.8 months in the update 2024, and a median OS of 28.3 months compared with CARTITUDE. After a follow-up of 61.3 months, 33% of the patients were alive and treatment and progression-free after 5 years. And this was a patient population that had 5 to 6 in the median prior lines of therapy. The median OS, 5 years, presented on last EHA. And this is retrospective data. Comparing these two, we for sure will never have a comparative prospective trial showing that these first impression from the phase 1 and phase 2 data holds also true in retrospective analysis, where cilta-cel outperforms the ide-cel with a reduction of 57% of the PFS hazard and 47 in the OS in the ITT group. So this comes not without some more side effects. So severe CRS is 7 times increased in the cilta-cel group in this retrospective comparative analysis. Delayed neurotoxicity, this is side effects we practically did not see with ide-cel, was increased, was 20 times higher, and a slight doubling of infection risk was also seen in these cilta-cel cohort. The CARTITUDE-4 was or is the phase 3 trial that compares cilta-cel versus standard of care, and here it's more narrowed down to PVD or DPD. We have here already the update after 34 months of median follow-up, and this actually was the first trial that could show overall survival benefit for the CAR-T construct in multiple myeloma. This also shows the higher MRD negativity rate on 10 to the -5 and 10 to the -6 level, and also how fast is the MRD negativity achieved, much faster with the CAR-T than in the standard of care arm. And the phase 1 data was again also in real-world clinical practice compared to the locomotion trial, which is real-world clinical practice, and could show that CAR-T treatment is, after matching, better to standard of care in that situation. So when it is best to use the CAR-T, we so far know from also matching studies like here, CARTITUDE-4, 2 to 4 prior lines of therapy, CARTITUDE-1, 5, 6 median prior lines of therapy. We see here that PFS and OS-wise, the earlier CAR trial shows a better result than the CAR-T trial on a later stage. Of course, the disease also is more aggressive there. So this is a picture from the recently really showed it EHA EMN guidelines. And this is second-line treatment all over Europe. Cilta-cel is already approved, but in Switzerland it's still in the third line. So we hope that this also comes to earlier lines. We even hope that maybe this is something that can challenge melphalan and autologous stem cell transplantation. We also participated in this trial. The data is not mature yet, but we will look what this is bringing us in the future. Very interesting study, head-to-head ACT melphalan versus cilta-cel after quadruplet induction. And this is a slide showing that it's important to effectively bridge the patients. You could say that's intuitively right, yeah, it is, but it has been shown here based on the paraprotein. After 25% of paraprotein reduction, this is kind of of course, artificial deciphering condition. And also here in real-world data with ide-cel and cilta-cel, the PFS is better, the better the bridging therapy worked. And when you do some correlative studies with soluble BCMA as marker for the tumor burden, you can also see that effector to target ratio matters in the progression-free survival probability of cilta-cel treatment. Now I switch to antibodies, and these are some, I have to speed up, I think, a little bit, some general remarks about bispecific antibodies. Maybe we can summarize this, that the tumor antigen binding domain has to be quite strong. The CD3 binding domain should be a little bit reduced in binding to avoid CRS, to avoid exhaustion, to get a good enrichment on the tumor side, and also the Fc domain is silenced to avoid complement binding and antibody-dependent cytotoxicity, maybe T-cell fratricide or other effects. So this is a nice overview of what we have. We have here talquetamab, we have here not yet cevostamab, but maybe in the future, and we have here teclistamab and elranatamab, and others are in trials, ongoing trials. The blinatumomab structure here, the AMG 420 and 701 has been terminated due to lack of sufficient efficacy and also practicability, because these small compounds had to be given at least the 420 continuously. The 701 did not perform well. So I will quickly go through this. This is the pivotal majestic teclistamab 1 trial, phase 1 trial, heavy pre-treated patients with an overall response of 63% and also very deep responses. Here, 45% of the patients were greater than CR. This bispecific can induce a median duration of response of nearly 2 years, a median PFS of 1 year, and a median OS of 22 months. Safety-wise, it has to be mentioned that cytopenias, infections, and CRS are there. Not a major problem. The CRS is of low grade, but in the COVID era, COVID was a huge problem with also grade 5 events. Talquetamab is a little bit better in this infection theme. It also induces nice responses, and here in prior T-cell redirecting therapy, 65% overall response. The off-target effects, skin, nail, tongue, so taste is affected, I already mentioned, but very low grade 3 and 4 infection rates in this trial. And here you see also a comparison of teclistamab and talquetamab versus, again, the real-world locomotion and moment treatments, so improval of PFS. Cevostamab, I will skip in the interest of time to say something about sequencing. Similar overall response, 70%. You can roughly say a bispecific can induce 60 to 70% of overall response in myeloma. This is an overview about the interesting trials that are ongoing. I think this one is interesting. Teclistamab in the induction phase, redirect TT is already published with a combination of talquetamab and teclistamab. And what is particularly interesting is cevostamab after CAR T as a consolidation to increase CAR T cell efficacy. This is now a slide after T-cell redirecting therapy or BCMA targeting therapy here of teclistamab. This was the majestic cohort C. So you can see that after antibody drug conjugates, after CAR T cells, you still get a response in 50 to 55% of patients. The same is true for elranatamab. Elranatamab is the other very efficient BCMA targeting bispecific. Also here, you see responses in the 40s and 50s by prior ADC and by prior CAR T cell treatment. So these substances are even working after CAR T cell therapy. Also, the talquetamab, I showed this slide before, can induce response in 64% after prior T-cell redirecting therapy. The other way around, it doesn't look so favorable. These are real-world data from ide-cel treated patients after they got a prior BCMA-targeted treatment, prior belantamab, prior BCMA bispecific. All these patients that got a prior treatment responded less well. Even so, in the silver cell treated patients, a little bit less reduction, but still loss of 20% of efficacy. It's important to look at the interval between the different treatments. So less than 6 months is bad. More than 6 months, it's much better. And this is also here true or shown in the curves, in the PFS curves after any prior BCMA target therapy, and here with the time 6 months and for deciphering the treatment. Yeah, these treatments are toxic, and maybe I quickly say something to CRS and ICANS. We try to prevent this with bridging therapy to reduce the disease burden. We know that we have less toxicity after an adequate reduction of disease burden. For example, the neurological side effects are going down if the patient is in a good remission. We have a lot of possibilities here with supportive care, with tocilizumab steroids, with anakinra. For TPRC5D mediated toxicity, it's a little bit difficult. You can do mouthwash rinses, but it's not really satisfying. Delayed neurotoxicity is a problem. I already said that it can be mitigated by having effective bridging therapy. Of course, we work together with neurologists and apply steroids IV if there are cranial nerve palsies. For the very rare event of Parkinsonism, it's quite difficult. Looking at infections, we have the whole spectrum, like with an allo patient, and we have to be aware that these patients have to be, and they are, cared after CAR T-cell therapy in our department like an allo patient. We need prophylaxis in the beginning against bacteria. We need viral and pneumocystis prophylaxis later. And we have to, and we had to learn with the bispecifics that we have to substitute also in these patients IVIG, as you can see here. With the different levels of infection in the observation and in the primary prophylaxis group. These are my final considerations. I would like to highlight the amazing summary, the amazing overall survival of 5 years in the CARTITUDE-1 trial. This is the longest follow-up data we have so far. CAR-T is a one and done therapy. So this is something I think it's very important for the patient. You showed this case, Cosima, where a patient is over years and years and years under continuous therapy, and then he is able to get something that is given, and in the best case, he has a long remission rate and treatment-free interval. Sequencing therapy, the available data, also from the real-world point to CAR-T first, bispecific second. Of course, bispecific antibodies have their place in a rapid off-the-shelf product where efficacy is quickly needed. Rapid progression after quadruplets. We had these high-risk patients. We have elranatamab approved here in second line in Switzerland. It is very important to have the supportive therapy and effective bridging to have successful CAR-T and bispecific treatment with less toxicity. And FcRH5 could be something that is the next target for either bispecifics. It's tested in trials or even CAR-T. With this, I would like to thank you for your attention. Take questions. Marcus.
Yeah, so I still have a question for the sequencing, because there's a lot that we are uncertain about so far. So, and that refers to both bispecific prior or post CAR T-cell therapy. So, practical issue, is there any good knowledge how long the break between the last effective dose of a bispecific and the T-cell selection or lymphocyte selection should be? So last dosing of a bispecific and then lymphocytic apheresis. Is that clear?
No, it's not really clear. We try to have a washout period. What I learned is that it's something like 3 to 4 to 5 weeks. But of course, if the patient is or the disease is aggressive and you have then a pause, it's not something that you really want. Of course, ideally, one would collect before doing a T-cell redirecting therapy, if this is possible. we often have the situation that a patient is progressing, and then we have to decide between using a bispecific immediately or doing something maybe less effective in the meantime to accomplish a good collection of CAR T cells. And we had, I have to say, good experiences with the sequencing of doing the apheresis and using then hitamab, because this is a drug that uses really fast responses. We saw really nice remissions with this, and on the other hand, this is something that you don't want to really give for years because of the side effects on skin and even in the taste. This is something that is quite affecting the life quality of the patients, and then going to the CAR T in remission. But
so the usual sequence is to select or to do the lymphoapheresis and then give the bispecific and then
yes,
give the CAR T cells.
I think
we never did the other sequence to treat first with the bispecific, then a washout, and then select for.
There you have the tonic signaling with the bispecific. You have the exhaustion of T cells, and then you want to collect the T cells. I think this is more difficult to get a good product.
And if I'm allowed to, the after CAR T cell therapy, if then bispecifics are used, that's a rare situation. But I recall a case where I believe we saw CAR T cell expansion upon the application of the bispecific, having some tonic signaling on the CAR, plus the CD3 signaling via the regular TCR that somehow favored then the remaining expansion. Is this something that is described in the literature?
I think this could be a good strategy. And actually, I mentioned this STEM trial with the FCRH5. They use the cevostamab, also the bispecific directed CD3 FCRH5 after CAR T cell treatment as a consolidation or signal enhancing treatment. Yes, I think this.
Thank you.
So thank you very much. I think we have to move on to our second session. So welcome. We'll focus on lymphoma. My name is Nadia Turby. I'm a hematologist at the University Hospital of Zurich. We are very pleased to have a very distinguished lineup of speakers tonight. We'll start with Dr. Marco Bühler, who will give us an insight on pathology in lymphoma, continue with Professor D'Amore, who will speak about the treatment in T-cell lymphoma, and finish with Professor Ikosun on biology and treatment of indolent lymphoma. So our first speaker is Dr. Marco Bühler, a senior pathologist specialized in hematopathology and molecular diagnostics, with a particular focus on lymphoma, reflected in his research. He will speak on modern pathology in lymphoma. Thank you.
Thank you, Nadia. Yes, I have 15 minutes, so I thought about showing you a bit what we are doing here at the hospital, starting with how does the modern workflow look like in our opinion. You can see here we received a lymph node with suspicion for lymphoma in fresh state. That's how we like it. We took some fine sections and put them in formalin for standard FFPE processing. Here we have a piece that we sent to hematology for FACS immunophenotyping. And then, of course, we want to do some additional things. So we are doing some biobanking, freezing some pieces of tissue, and also sending something to Thorsten's group for things like drug screenings. When you have a fresh lymph node like this, the first thing you can do is you can do a touch imprint. This is very fast. You get a slide after 5 minutes. You can look at it and have an idea what it might be. So here you see these cells. They have a particular chromatin, which is very fine. They have some indentation, quite monotonous. The next day, we will have the regular H&E slides. Here you can see this infiltration again of those cells we saw, a bit diffuse in appearance. And of course, immunohistochemistry. These are B cells. They express CD5 positive for cyclin D1, SOX11. So this is a clear case of mantle cell lymphoma. The piece we sent to hematology, you can see very nicely here, lots of B cells, CD5 positive. And here you have the nice thing of having the light chain on the surface shown. So this is a pretty straightforward case. We are doing a lot, so maybe for this case it was not absolutely necessary. But let's see a little bit more complex case. This is a 60-year-old patient with a known T-cell lymphoma. This is how the lymph node looks. Again, the architecture is gone. And here we have some medium-sized to large cells. They all express CD3. So these are T cells. They express CD4, have this loss of CD7, which is frequent in T-cell lymphoma, and expression of 2 TFH markers, PD-1 and ICOS. So the current dogma here is that CD4 and 2 TFH markers is sufficient for the diagnosis of a nodal TFH lymphoma, although the WHO acknowledges that it's not sure if this is actually enough. So here again we have flow cytometry. You can see this time we have lots of T cells. We see here again the CD7 loss, but what's weird is all these T cells express the gamma delta T cell receptor. We can see the same thing with immunohistochemistry. And so this, if you're familiar with immunology, this is a bit weird that a TFH, T follicular helper cell, is supposed to be a gamma delta T cell. We did some sequencing, and what's important here, we didn't see anything that is usually associated with TFH lymphomas, mainly a TP53 mutation. And this was shown last year that this is probably a type of lymphoma which is not well reflected. Gamma delta T cell lymphomas we know from extranodal localizations, but there are also few of these cases that happen in lymph node, and this we could publish Viola Vetter this month. Also, something that is important to me is to always say how important an excision is. This is the gold standard for diagnostics. You can see this is a large study from France. And you see over the years, this is something that is happening everywhere. The core and needle biopsies are increasing. But something they could show is that the amount of non-definitive diagnosis or equivocal cases are much lower when you excise a lymph node. We heard for myeloma, there's many new therapeutic options, but also for lymphomas. So you want to know which drug you want to give to which patient. So it's tempting to look at markers in pathology, do a kind of theranostic immunophenotyping. This goes well with the myeloma talks before. As an example, BCMA immunohistochemistry in plasma cells we are doing since some time. And now, due to popular demand by oncologists, we will also start looking at GPRC5D. But the question is, why are we doing it? So, you know, in solid tumors, there are some well-established scoring system, like for HER2 or PD-L1. In lymphoma, this is not something that is really well-established. One example could be the CD19 expression before CAR T cell therapy. It is not very clear that the expression level correlates with objective response rate. But it is true that after relapse after CAR T cells, one mechanism is a loss of CD19, which then you can also see. Another thing you could do, this is work done by Kevin Hofer, is finding targets in patients where you maybe have exhausted normal possibilities. So, like in this case, rare type of lymphoma, plasmablastic lymphoma, which could be targeted for a BCMA. So we obviously care a lot about proteins, much more than mRNA, for example, but immunohistochemistry has clear limitations, not only multiplexing, but also it's not really quantitative. So something we are doing in the research setting here at the hospital together with Thorsten, Christoph Messner and Valentina Boeva is changing the approach, not using antibodies, but using mass spectrometry. And what we are doing here is analyzing almost the entirety of our biobank to look potentially also for new markers. There's some preliminary data for mantle cell lymphoma, and you can then look at things like cytology. You can already see here that we have some differences between tissues. Molecular profiling is also something that it's talked a lot about in oncology in general. If you look at indolent lymphomas, you really have two things that are very, very characteristic for diseases. MyD88 in lymphoplasmacytic lymphoma, BRAF in hairy cell leukemia. The rest is not really entirely specific. Of course, you have some patterns in different entities. Me personally, I use sequencing mostly for diagnostic use if I may be not sure about the small B cell lymphoma. It has to be said that it's rarely a predictive test, and it is prognostic at times, especially TP53. But here again, we have to acknowledge that the field is not as advanced as, for example, in acute myeloid leukemia. And so, how can we improve this? Our departments, pathology and hematology, have now acquired a very powerful sequencers. We have new possibilities to do things we didn't do in clinics before, whole genome sequencing or transcriptome sequencing. My colleagues have already shown, this was published last month, that you can even do whole genome sequencing reliably on formalin fixed material. And here, this would be like a one-stop shop genomic characterization of lymphomas. So to finish, where do we go from here? like Professor Mey, I'm going to show a painting. And the School of Hematopathology, there's a lot of people in this painting. This person here seems like he's looking at some kind of screen. So morphology is maybe having a renaissance with digital pathology and predictions from H&E. So that might be the future. Then sequencing, sequence everything and not look at slides anymore. Immunophenotyping is also something that is changing a bit. But in the end, we have to figure out what makes sense so that you can actually use this information to the benefit of the patient. Also thinking about cost effectiveness in these times. Thank you.
So thank you very much, Marco Bühler, for this beautiful overview. I think maybe there is time for one question from the audience. Not? Okay, maybe I have a quick question. I think you mentioned it at the end, showing the picture about the AI, I assume, was referred to. Are you already using it? Where are the efforts there in the pathology team here in-house?
There are efforts, but we're not using it in clinics. Not for lymphomas, not for other things.
Okay, thank you. So now I'm honored to present the next speaker, Professor Francesco Annibale. He's the head of the hematology department of the University Hospital in Aarhus in beautiful Denmark. He's a leading expert in T-cell lymphoma. Amongst all efforts, he quite recently published the ESMO-IHA guidelines on diagnosis, treatment, and follow-up of T-cell lymphoma, which I assume was a big effort. We're thankful for that. And he will give us an overview on the guideline-based T-cell lymphoma treatment. So thank you.
Thank you very much for the kind introduction and for the invitation and hospitality to be here today to talk about these relatively new guidelines from the ESMO and IHA together. It's the first time they publish together on peripheral T-cell lymphomas in beautiful Zurich. This was the publication that appeared in May 2025, and you can see the names of those that participated in this effort. These are my disclosures. And just to give you an introductory flavor of what happened during the last decade, this was in 2015 when we published the last ESMO guidelines based on the revised 4th edition of the WHO classification. And just visually, without having to look into the small boxes and read what's there, you can see that in 2025, the number of entities, here I only took the primary nodal and primary nexus nodal, although the new guidelines also include the primary leukemic entities, just to have a fair comparison with the old guidelines that were only nodal and extranodal entities. But now, when we look at the amount of new entities, we can see that the challenge, recognize the challenge in T-cell lymphomas, which is they are rare and they are heterogeneous. And that is not easy in terms of the wish of running clinical trials in these patients and do it uniformly and in a logic and sequential way. What I try to do with this slide, which is enormously busy, is just to not to look at details, but more the pattern, the infrastructure. They are divided in primary nodal, as I said, extranodal, and leukemic entities. And we have the first line in the horizontal way, the first-line approaches and the relapse refractory treatments. Another thing that you can see as a pattern is the attempt to attract the attention of physicians to the importance of including these patients in clinical trials. Of course, only if they are available, but make them available and also learn something about the rare entities and not just, as we see in the literature, most in the information in the most common nodal subtypes and very little in the rest. Already up front here, I would like to approach one thing that has always repeatedly been a discussion topic, the one of consolidation, of what type, stem cell therapy, autologous versus allogeneic or case-by-case based approach in that context. And just to show you where the guidelines actually end up suggesting to consider consolidation in terms of autologous transplant, you can see they are the blue circles at the end of the path, the algorithm of chemosensitive nodal entities, and also two extranodal ones, which is the disseminated or advanced stage breast implant associated ALCL, which is suggested treated like the nodal version of the disease, and also enteropathy associated T-cell lymphoma. In this respect, I would say that in the group we also, and in the text of the guidelines, we put emphasis on the fact that the risk profile of the patient has big importance. So it can end up with, if the patient is fit enough, if there is a good donor, if there is a very high risk profile, that we maybe choose an allogeneic approach, even if the guideline ends up suggesting the autologous approach. But at the end of the presentation, I have a slide also with a new French trial that will show you some data that are promising in the context of enteropathy-associated T-cell lymphoma. All the red circles are where the allogeneic intervention is suggested or considered. And that would be the aggressive entities, extranodal, typically hepatosplenic T-cell lymphoma, and the mitral, the monomorphic epitheliotropic intestinal T-cell lymphoma, earlier called type 2 enteropathy associated, which was a little bit difficult to pronounce because the patient didn't have any enteropathy, and the aggressive entities in the primary leukemic, and the entire setting of relapse refractory patients, also in case of chemosensitivity, suggested to be approached by allo. And the introduction of our Asian colleagues in the group of authors was one of the reasons that the discussion there ended up suggesting a case-by-case approach, depending on the factors I mentioned before, risk profile and tumor biology, and also EBV status for the extranodal NKT, the being nasal or extranasal, to choose whether to consolidate at all, and if so, with which approach, the auto or the allo. And let's look at this trial, the result of this trial, which was the French auto allo trial, French-German collaboration, that we have in two parts, if you want. One primary analysis that was at 3 years, event-free survival as primary endpoint, and a long-term follow-up with a 7-year event-free survival that was published last year in Journal of Clinical Oncology. And what you see very, very, very easily in this context of numbers is that the autologous transplant had a significantly lower occurrence of treatment-related mortality, whereas the relapse rate was significantly higher than the allo, and the exact opposite for the allo approach. So the author's conclusion was to choose upfront autologous transplant as the modality for transplant-eligible patients. We say in the guidelines that should be for the nodal, as I showed you, and some extranodal entities, but not all. And the allo, the conclusion of the JCO paper was not recommended as part of first-line consolidation. And in the guidelines, we make some notable exceptions that relate to the recommended upfront use of allogeneic transplant in chemosensitive hepatosplenic T-cell lymphoma and mitral patients and aggressive leukemic entities. In the refractory setting, there is no other comment than if the patient is transplant eligible and if there is chemosensitivity, a consolidation with the allo is the right approach to choose. Just for your information, there is a trial that started in 2022, already accruing patients during the last 5 years from the French group LISA, the transcript trial, where it is at the moment randomized whether a backbone CHOP or CHOP-like, including etoposide or brentuximab vedotin, is treated with consolidating autologous transplant or with observation. And these are only patients that are PET-CT based, regarded to be in a metabolic complete remission. The patients included in this trial are nodal PTCL, the TFHLs, the PTCL NOS according to the newest criteria of that diagnosis, and ALK negative ALCL. The ALK positive are, as we are mostly used to approach, without high dose or aggressive consolidation. And a brief comment before going into specifics and specifics that are selected according to the time we have today to talk about these things. Just to mention for you that even more close to today, as in August 2025, there was the publication of ESMO CPG clinical practice guidelines for all lymphoma subtypes, and they will be presented in Berlin at the ESMO Congress next month. The difference of these guidelines that are meant to be updated once or twice a year is that they include all entities and recommendations in that guidelines for T-cell lymphomas were just almost one-to-one with what is written in the main manuscript of the ESMO EHA guideline, and it only pertains nodal entities. The extranodal and the leukemic are not included in those. So if you want some more granular, some more detailed information on single subtypes, then you have to look at the specific guideline. So what about staging and risk assessment? Well, in those parts of the world where PET-CT is available, diagnosis based on PET-CT is preferred as imaging modality simply because PET-CT is better to identify the often existing extranodal involvements of T-cell malignancies, and of course not pertaining leukemic cases. In all cases, a bone marrow biopsy is recommended for accurate staging, as opposed to many B-cell settings. And rebiopsy is recommended at relapse or progression. And for nodal PTCL, the IPI is still the preferred prognostic tool. And this is based on publications like that. For example, collaboration of the Nordic group with the Mayo Clinic and the BCCA in Vancouver, comparing different prognostic indices, and ended up saying that the IPI that most of the physicians are perfectly comfortable with is still what you can prefer for PCL-NOS and ALK-negative ALCL, and a little bit less, but still also very useful in angioimmunoblastic lymphoma in that publication of 2019. For response and follow-up, it is also supporting the use of interim evaluation by PET-CT, which has a predictive prognostic value, predictive towards survival, but the intervention based on interim PET-CT has not shown, therapeutic intervention shown to change the outcome, and that was particularly based on the PETAL trial, which is shown in the next slide. Diagnostic imaging should be repeated at the end of treatment, along with a bone marrow biopsy if the bone marrow was involved in the beginning. And for patients in CR, the recommendation is to follow at 3 years and 5 years if they have been through autotransplant to be able to catch signs of myelodysplasia. So routine surveillance is not recommended either with CT or PET-CT, and EBV DNA monitoring, particularly in patients with NKT, extranodal NKT, is recommended. This is just some of the literature supporting the interim PET-CT and the fact in the PETAL trial that it was not affecting the outcome to take a treatment decision based on interim PET. So what about first-line treatment in PCL-NOS and TFHL? One thing that had been discussed in the group was the intensity of treatment in a localized disease. There is a very little literature about that. This is from the Dutch group done on stage 1 and basically based on registry data, showing that combined modality with chemo and radiotherapy is better than a single modality of each type. And this is from the collaboration of the Swedish and Danish lymphoma group, showing that treatment with 3 to 4 cycles was not significantly different from the use of 6 to 8 cycles. So what about the discussion on the etoposide CHOP that was started by the observation in the old Francesco trial that etoposide had an impact which was significantly improving outcome, in particular in ALK-positive ALCLs. And then the Nordic trial combining the addition of etoposide to CHOP and the autologous transplant consolidation was published by our group back in the days in 2012, and had, which for us historically, according to the registry data we had from our population-based registry, was something between 10 and 20% better than the historical data. These observations have been corroborated by some supporting registry data from Sweden, for example, and more recently in 2022 from the Dutch group based on their registry, where they all consistently find, and I will show you that in a moment, also for when we talk about ALCL, they find that etoposide outside ALK-positive ALCL has a dubious additive effect, and that autologous consolidation in nodal lymphoma seems to have some impact. Which new drugs have now access to the guidelines? There are many interesting things happening out there, but the level of evidence is still not sufficient to put it in a general recommendation read by a large international public. So the 5 ASA story started with a case series from the French group back in 2018, and last year the Oracle study was published in Lancet Hematology in 2024. That was a negative study because the ambition of of having a positive result was leading to a request of a p-value of 0.025. So the 0.04 obtained from this trial was not leading to a positive trial conclusion. But subset analysis show that 5-azacitidine, particularly in TFH lymphomas, has a role. And this is also demonstrated by a subsequent phase 2 trial with CHOP combined with oral 5-AZA, where you can see that the 2 years PFS and OS were 65 and 68% respectively. You can see also the schedule of the trial. And based on this trial and observation, there is now a randomized phase 2 taking place in the US, the Alliance trial, having 3 arms and stratifying according to age whether the patients receive CHOP or CHOEP. One arm oral azacitidine plus CHOP or CHOEP, the other one PI3K inhibitor, duvelisib, plus CHOP or CHOEP, and the third arm, the comparator, CHOP or CHOEP alone. And the last data I put here, these are not in the guideline, but there are data that show you that there are combinations with 5-AZA. This is subcutaneous, not oral, that seem to improve response rates and also at least short follow-up endpoints. This is a Chinese study combining chidomide plus subcutaneous 5-AZA and CHOP. So, and as far as anaplastic large cell lymphoma are concerned, we all know the results of the Echelon-2 study. More than 70% of all the patients were of ALCL histology, so it's strongly dominating. The best results were obtained for ALK-positive lymphomas, and the non-ALCL histologies were not doing particularly well. For those that have seen the single, they've never been published, but they've seen the single curves of the single entities, the non-ALCL entities were not that impressive. So these are two sets of data with etoposide in ALK positive. You can see here the French group published a total of a pooled analysis of patients with ALK positive anaplastic lymphoma included in prospective trials from the German group, the French group, the Japanese, and other groups, also from the Mayo Clinic. And you can see in the lower figure here panel that the response for CHOEP was 90% or 90 plus at long-term follow-up. The same was seen in registry studies, and the addition of autologous to subsets of the Echelon by the Echelon team ended up also finding a PFS with an HR of 0.36, reflecting a 64% reduction in the risk of an event in patients who underwent stem cell transplant compared to those who did not inside the Echelon-2. And the same group of authors also tested regimen with the addition of etoposide to BV-CHP and autologous, and had CR rates around 80% with overall 2-year progression-free survival of progression-free of 60% and overall of 86. This is the last slide with the rearrangements that have been discussed recently of DUSP22 and particularly TP63, showing you the 8 studies that are around in the literature. And you can see 5-year overall survival numerically in the table and as columns in the lower part of the figure. And the dark blue columns are the one depicting DUSP22 rearrangement, and the dotted line, red line, shows you the 60% level of 5-year-old survival. So 6 out of 8 of these studies have 5-year overall survivals for DAS22 rearranged ALK-negative ALCL, which is over 60%, and 2 studies are lower than that. It was the BCCA study from Vancouver and the US study from Stanford and MD Anderson. There is consensus that TP63 in the 2 studies that have been published with that information has a anomalous outcome, but the guideline does not regard the present information on outcome of DAS22 to be mature enough to take final clinical decision upon that particular feature. For the breast implant, I would like just to show you how we approach according to the stage. For those that have 1A, 1B, and 1C, and here is an adapted stage from the guideline, which is based on earlier stagings proposed by US and UK guidelines. There is unblocked capsulectomy, and as soon as there is a stage 2 with penetration of the capsule and outside the capsule and involvement of a single or local regional lymph node, there is unblocked capsulectomy involved site radiotherapy, and systemic treatment like for disseminated or advanced ALCL, if it's more disseminated than that, with capsulectomy as well. Just on top of what I just said, importance that to the fact that this is has to be a multidisciplinary approach. Representative biopsy with excision, if possible, should be obtained if there is a suspicion of regional lymph node, not needle biopsy if possible. And the removal of contralateral implant is recommended, particularly if it is textured, because it's all, as you know, only textured implants that have association with BIACL, and mastectomy is not recommended. There are data that emerging on association with BRCA1 and 2 and PC53, Lee-Fraumeni syndrome, and this type of lymphoma. But at present time, it is needed to have more data, and it is not mature enough to recommend a broad genetic testing. The last things I want to show you is this data from 2024 that was included in the guidelines in the last minutes before sending out to reviewers, and that is the combination of asparaginase containing regimens with checkpoint inhibitors. So the guideline in the last bullet says that based on this trial and encouraging results from that, the inclusion of anti-PD-1 antibodies can be considered. And I want to finish off with enteropathy-associated T-cell lymphoma, where this trial, this is the last slide, this trial, the AITL-001 from the French group, presented with the data we had in the guidelines on an abstract from Blood 2021, has just been followed up by a longer follow-up. They presented in Lugano 25, where these patients had, at a median follow-up of 5.3 years, a 5-year progression-free survival of almost 60%, and overall survival of the same level. So a confirmation that trials that are specific for entities are also able to bring us forward in entity-specific approaches. Thank you very much.
So thank you very much. We know you had only short time for a very heterogeneous group on difficult diseases. So maybe time for one question. Yes.
Yeah, Francesco, thanks a lot. It's a lot of ground to cover, but I was a bit confused. So what are you now doing in ALK-positive T-cell lymphoma?
Well, in ALK-positive in Denmark, we don't necessarily use PV, and there is a tendency, and that was also backed up strongly by the Dutch group. Actually, it was a Dutch group that brought that about, and was because they also have own data from the registry, as I showed, but additional data that were not in this presentation. So, if the ALK profile, if the clinical profile and biological profile is very aggressive, we may be even thinking of the CHEP-PV, which is mentioned in the guidelines.
Thank you very much. That would have been my question too. So I give the word to Thorsten Zenz.
Yeah, I was wondering when an anti-PD-1 antibody is used, is the biologic activity due to the ADCC function, or is there also an element of signaling via PD-1 into the PD-1 expressing T cells?
But that's a good question. I don't know if there are data available to answer that. Maybe even both could be the case. But in the clinical setting, at least the patients I've seen and treated with that, there are really impressive responses. So people are pushing to have it in first line.
Okay, thank you. We will move on. So I'm sorry, Jessica, the speakers and the chairs have taken a little bit from your time, but I'm sure we will manage. So and it's Jessica Ikosun comes from the Barts, and she's a professor of translational cancer research, but also has an honorary consultant position in the clinic, and she's an expert on all sorts of B-cell lymphomas. So thanks for joining us, Jessica.
Thanks very much, Thorsten. It's really nice to be here. Thank you for the invitation. And I realize I'm the last talk standing between everyone and drinks, so I'm going to try and keep to time. So I'm going to talk about a bit of a mixed biology and treatment of indolent lymphomas. Now, I'm sure most of us recognize that rituximab has been the poster child targeted therapy for B-cell lymphomas for probably over 25 years. And the question really is, have we moved on from sort of rituximab, particularly for B-cell lymphomas? So what I'm going to try and do is I'm going to talk a little bit about biology of indolent lymphomas. I'm also going to talk a little bit about how we sort of moving from rituximab, so where we were in terms of treatment, where we are presently, and where I think we are going with treatments. So to such a learned audience in this room, you probably don't need this slide, but it's just to sort of remind us that when we talk about indolent lymphomas, we're really talking about entities like follicular lymphoma, marginal zone lymphoma, and lymphoplasmacytic lymphoma. And these account for probably about 40 to 50% of all non-Hodgkin's lymphomas. So again, just very briefly, follicular lymphoma, the commonest indolent, slow-growing NHL. Typically older patients, as we would expect. Marginal zone lymphoma, a couple of different entities. We have splenic marginal zone, nodal, and extranodal. There is a well-established link with chronic infections and also autoimmune conditions. And then lastly, Waldenstrom's, which is obviously a rarer entity and associated with an IgM monoclonal gammopathy. Most of the symptoms that the patients have and complications are as a consequence of this IgM paraprotein deposition, so things like hyperviscosity, neuropathies, for example. So what's in common with most of these indolent non-Hodgkin's lymphomas is they have this very classic natural history, and I'm going to use follicular lymphoma as an exemplar. So most of these indolent lymphomas most of the patients have very long natural history. And what we also know is that they're very treatable, but we know that actually a lot of them, they're not curable. So these are the typical curves we'll see on the Kaplan-Meier. There's no plateau on the curve. Most of these patients will relapse in time. And when they do relapse, they tend to have multiple relapses, and the subsequent relapses, they have much shorter progression-free period. And we also know that there are some high-risk group of these patients, some that have a more aggressive behavior, whether that's being refractory to standard therapies, or whether that's transforming to aggressive lymphomas like diffuse large B-cell lymphoma. And each of these indolent entities have varying risks of transformation. So when I think about the treatment of indolent non-Hodgkin's lymphoma, I think that obviously this was probably where we are a little while ago. Chemotherapy has been the mainstay or the backbone of our treatment. But I think that what we're seeing is that we are probably reducing our reliance on other conventional therapies like splenectomies for splenic marginal zone lymphoma, radiotherapy, and indeed transplant, autologous and allogeneic transplant. And what's probably happening is we're moving, perhaps evolving towards more targeted therapies. Now, I always use this slide when I talk, and it's a little bit annoying because I have to keep changing this slide every year, because this is a great thing for our patients because of the pace of approvals in indolent lymphomas, and particularly in follicular lymphoma. So here you can see these are therapies that have been approved for relapse refractory follicular lymphoma. These are mostly sort of targeted or immunotherapies, and you can see the last 4 or 5 years, there have been many of these therapies approved. Approval doesn't mean it's available in every country, so these are FDA-approved therapies. We also have a number of CAR T-cell therapies that are approved in relapse refractory follicular lymphoma. If we look at marginal zone lymphoma and WM, we can see obviously not as many therapies, but it's still, for these kind of more, particularly WM, rarer entities, we still have a number of targeted therapies that have been approved. So I'm going to switch tack a little bit, and I'm going to go to talk about the biology first, and we'll come back to treatment. Now, one of the things that has really accelerated in parallel, so as we are having evolution of therapies, but actually our evolution and understanding of the biology has really sped up. And I think a lot of that has been due to the advent of technologies. So we pretty much have a very good genetic fingerprint of pretty much all lymphomas, I would say. And what I think is really clear is that there are some, we pretty much have a genetic signature of most of these indolent non-Hodgkin's lymphomas. There are certain trends. There are very few genes that are synonymous with only one lymphoma type. Something like BRAF, where we see these mutations very commonly in hairy cell leukemia or MYD88 in LPL, but actually many of these genes are also mutated across a number of the lymphoma entities. I think what's becoming apparent is that rather than just looking at single genes, we're starting to see that there are biological pathways and processes that are maybe more synonymous with those lymphomas. So for example, in follicular lymphoma, there are many genes that are typically mutated that affect the kind of epigenome. Things in CLL and marginal zone, the mutations tend to affect genes that are involved in signaling, cell signaling, and then things like DNA repair and so on are also affected in some of the lymphoma entities. Now, I'm going to try and talk about each of these very briefly. So in follicular lymphoma, I talked about this sort of enrichment in mutations in epigenetic regulators, and over probably about 90% or more of follicular lymphoma patients, if you were to sequence their tumors, they will have mutations in one or certainly more than one of these epigenetic regulators. And what we know is that these epigenetic regulators, if we think of them like a conductor in an orchestra, what they're really doing is they're turning on sections of genes or section of the orchestra that are going to be beneficial to keep the lymphoma alive. And then what they also do is they'll turn off sections of the orchestra that are going to be detrimental for them. So they'll turn off things like, the host immune systems, for example, or MHC, things like to do with immune evasion. So they basically can turn on and off genes that are going to be beneficial for them. And ultimately, they obviously affect many downstream biological pathways. Now, we know in large cell lymphoma, in diffuse large B-cell lymphoma, we're beginning to see that there are lots of molecular subtypes. So there's a lot of genetic inter-patient heterogeneity. So patients with exactly the same lymphoma subtype are molecularly or genetically different. And do we see that in follicular lymphoma? starting to see that in actually many of the indolent lymphomas. So if you study many of these patients' tumors, we're starting to see that there are different molecular subgroups or genetic subtypes, and some of these are associated with outcome. So for example, here in this study, this particular molecular subtype that is enriched for TP53 mutations is associated with a worse prognosis. So I think we're going to start to see a lot more of this kind of interpatient genetic heterogeneity across the lymphomas. What we also are seeing is that not only is there difference genetically or biologically between patients with exactly the same lymphoma subtype, but if we look at a patient over time or in space, their lymphomas are constantly evolving. So we've done a lot of this work over the last sort of 10 years or so. In many indolent lymphomas I talked about have this very protracted clinical course. Their disease is going to be coming back or relapsing. They have treatments and then they relapse. And what happens is that over time, they're genetically evolving as well. And we've been able to show this sort of genetic evolution in follicular lymphoma and how we think that relapses originate from a kind of a genetic ancestor. But also what we've been able to show is that many of these patients with these lymphomas present with advanced stage disease. They've got lymphomas in many different compartments in their bone marrow, in multiple lymph nodes. And what we're beginning to see is that if you sequence the tumors in different compartments, there is also this kind of genetic heterogeneity. So you have the spatial heterogeneity. And that may present some problems if we're starting to use targeted therapies, because if your target is in one lymph node or in the bone marrow, you may clear the lymphoma in one compartment but not the other. So this kind of intrapatient heterogeneity is also going to become quite important. So that's follicular lymphoma. If we move to marginal zone lymphoma, what we do know is that this is, as we say, is associated with certain infections, for example. So there are certain predisposing factors. So for example, H. pylori, which causes a gastritis. And what we know is that this basically induces this kind of chronic inflammation, and this chronic inflammation leads to an expansion of B cells, so B cells that are typically autoreactive, so these clones of B cells, and this leads to the development of these marginal zone lymphoma. The microenvironment is very important here, but what then happens over time is that these B cells then acquire additional genetic alterations that then renders them independent of the kind of impact of the microenvironment. So this is a kind of a multi-step pathogenesis in marginal zone lymphoma. What we also know is that when we look at these specific genetic events, they typically hijack specific signaling pathways. B-cell receptor signaling, NF-kappa B, for example, the Notch signaling pathway, are very commonly impacted by genetic alterations, whether that's mutations or chromosomal changes. So just as I'd shown you in follicular lymphoma, if you study many, many patients, we'll start to see that there is an increasing molecular taxonomy. So in splenic marginal zone lymphoma, this is work that was conducted in over 300 patients, and where they performed sequencing of these patients' tumors. What you can see is that there were 4 different molecular or genetic subgroups. There are 2 main ones, one called the NNK cluster, which is mostly enriched for mutations in NF-kappa B and Notch signaling, and then another that is enriched for mostly DNA damage, so things like TP53 and ATM. And again, just as we saw in follicular lymphoma and indeed a diffuse large B-cell lymphoma, certain molecular subtypes are associated with better or worse outcome. And again, I think that this allows us to understand that this sort of interpatient heterogeneity, the underlying biology is also quite important, even within individual entities. And the last sort of pathogenesis I'll talk about is WM. I'm sure most of us are familiar that many of these patients, over 90% of them, will have mutations in MYD88, and they commonly have a sort of a missense mutation, the leucine, that is basically converted or mutated to a proline. And we know that the MYD88 is an important adapter protein, and it basically dimerizes and acts as a scaffold protein that allows the recruitment of other molecules, such as IRAK1 and IRAK4, for example. And the real impact of this sort of the MYD88 is to basically recruit all of these proteins onto this complex, and it allows the kind of upregulation of specific signaling, pro-survival signaling pathways, and ultimately it triggers NF-kappa B signaling. So what I've tried to show you is that for some of these lymphomas, we know that the B-cell receptor and NF-kappa B signaling are really important, very essential for the pathogenesis of these lymphomas. So therefore, the field is focused on trying to target some of these different components, whether that's PI3 kinase, whether it's BTK. And so let me start with sort of a story that I guess that we know. PI3 kinase inhibitors are, a downstream component of B cell receptor signaling. There were 4 FDA-approved PI3 kinase inhibitors. Most of these targets, the PI3 kinase inhibitors targets the PI3 kinase delta isoform. The overall response rate is probably about 40 to 60%, duration of response about a year or so. But despite all of these therapies that were approved, mostly in follicular, relapsed refractory follicular lymphoma, and one of these in marginal zone lymphoma, many of these PI3 kinase inhibitors were then withdrawn a couple of years ago. And most of that was due to the fact that these therapies, although sort of effective, had many complications. They had a lot of delayed immune-related toxicities, which made it very difficult, particularly think that these are indolent lymphomas, and patients were suffering with many of these toxicities associated with these therapies. So that's PI3 kinase inhibitors. What about BTK itself? We know that there are a number of BTK inhibitors approved. We've got first generation ibrutinib, for example, second generation acalabrutinib, zanubrutinib. And we know that these in BTK inhibitors are highly effective in marginal zone and WM. Most of these trials are shown here, mostly in the relapse refractory setting. And you can see here how effective they are. But one of the things I want to also point out is that we're very good at historically lumping entities together. So if we look at BTK inhibitors, I showed you the slide before, efficacy in marginal zone and WM. But if we look at follicular lymphoma, overall response rate as monotherapy of only about 21%. So if we look at other types of therapies, BCL2 inhibitors, venetoclax, very effective, highly effective in CLL, but again, monotherapy in follicular lymphoma, overall response rate of less than 40%. And again, if we look at checkpoint inhibitors, very effective in Hodgkin's lymphoma, but actually abysmal in follicular lymphoma. And I think that what I really want to show here is actually to remind us that actually each of these subtypes have different biological dependencies, and we shouldn't just try and lump everything together, because some of them are dependent on very specific biological pathways that are better targeted by different therapies. So lenalidomide. So we also looked at signaling pathways. Lenalidomide is also a therapy that is approved in relapsed refractory follicular lymphoma and marginal zone lymphoma. We know that lenalidomide binds to its activity is driven by the cereblon, which is the kind of E3 ligase, and we know that it has mostly immunomodulatory effects, so basically modulating the T cells and NK cells, and this is how it has its activity. So those are things that are approved. So the question is, where are we going, or where are we trying to go with these therapies, and why might we actually need new targets? We know that some of these existing therapies are effective, but actually we could improve their efficacy. We also know that in time, some of these targeted therapies develop resistance, or the patient's tumors in time develop resistance, and ideally we want therapies that have less side effects. So I kind of think of this as, we're in sort of in different eras. So currently we're probably in a kind of Nokia, the old style sort of mobile phones. We have these different therapies that are targeting either cell signaling pathways or the surface markers, anti-CD20, for example. But actually what we're trying to do is really have some upgrades, right? So we're moving from a kind of Nokia brick phones to kind of your iPhone 17 or whatever it might be these days, and taking pathways that we know are relevant to the biology, but actually making some improvements to that. So it's the same pathways that we know are important that they might be represent the Achilles heel or the vulnerabilities of these lymphomas, but how do we improve on the efficacy of those therapies? So we know, for example, BTK inhibitors in time, that most of the approved BTK inhibitors for indolent lymphomas are basically, they are irreversibly binding and they're covalent BTK inhibitors. We know that most of these patients in time will acquire genetic resistance or non-genetic resistance to ibrutinib. And so they are basically newer BTK inhibitors, so you have these kind of non-covalent reversible BTK inhibitors like pirtobrutinib that have very high selectivity for BTK, and we know that are effective even in patients that have acquired resistance to BTK, such as the C481S mutation with BTK. So new ways of improving the efficacy of BTK inhibitors. There are alternatives to BTK inhibitors, so we're starting to use approaches like PROTACs, so basically PROTAC therapies, which are basically proteolysis targeting chimeras. And essentially what they do, these are degraders. So rather than just inhibiting the protein or the enzyme, you actually have therapies that are degrading the protein. And this may be particularly useful when patients develop resistance. So we have these new BTK degraders, and also we have these IRAK4 degraders, and things that combine the activity of the kind of BTK and the immunomodulatory drugs like lenalidomide. So the other thing, of course, we've already heard about immunotherapies, so T-cell engaging immunotherapies like bispecifics and CAR-T. And we know that many of these are available for indolent lymphomas. So the bispecific antibodies typically target CD20 and also obviously the CD3 component. And then for CAR-T, mostly targets anti-CD19. And there are a number of these bispecifics and anti-CD19 CAR-T that are available for indolent lymphomas. So really just to kind of give you a bit of a high-level summary of some of these therapies, we know bispecific antibodies as monotherapy in relapsed refractory follicular lymphoma is really highly effective. And what this table just shows is just summarizing these bispecific antibodies. You have overall response rates of 70 to 90%, very high CR rates. And actually, the CR rates are very high, but it also very high even in high-risk subgroups. So patients that have refractory disease, have had many lines of therapy, those that are early progressors, what they call these POD24 patients. So these bispecific antibodies are very, very effective, certainly in relapsed refractory follicular lymphoma. And what about CAR-T? I think in CAR-T, we probably will never see such a high response rate in relapsed refractory follicular lymphoma. There are 3 different CAR-T products that are approved or FDA approved: Axicell, Tezocel, and Lizacell. And again, you can see here very high overall response rates and very high CR rates. Now, one of the things to say is obviously these data is still maturing, so we don't have the Axicell probably has the longest follow-up, Lizacell probably less than 18 months or so. And I think that the question is whether are these therapies curative for indolent lymphomas like follicular lymphoma? And I think time will tell. We're looking at median progression-free survival about 4 to 5 years. So it's perhaps not curative for all of the patients, maybe for a small subset of patients. But the other thing to say is that the high-risk group of patients, so there's POD24, there's early progressors who tend to have a very difficult therapeutic journey. We know that actually even with CAR-T, that these patients tend to do a little bit worse than those that do not experience early progression. And I think the question really is how durable are these responses? Do we think it's going to be curative for a proportion of these patients? And I think time will tell. But I think looking at the curves, we can see that patients are still relapsing, maybe not as many, but patients are still relapsing, indicating that actually there are some patients that may require alternative therapies. What about things, so that's, if we think about the therapies that we have existing so far, they are, I would say, a little bit more blunderbuss. They basically target the surface or target the immune environment. Are there ways to focus very specifically on the biology? So in follicular lymphoma, probably about 20% of the patients have mutations in EZH2, which is a histone methyltransferase, an epigenetic regulator. We had this study looking at a selective oral inhibitor called tazemetostat. And this was a phase 2 study looking at what they did was they genetically profiled the tumors in these patients, looking for whether they were EZH2 mutated or wild type. And the patients that were EZH2 mutated had a slightly better response rate, but you can see that actually the progression-free survival is not that different between those that were mutated versus those that were wild type. And I suspect that because the reason for this also is that remembering that many of these lymphomas have multiple mutations. They don't just have one mutation. So you're really just targeting one vulnerability, and that these lymphomas may have a number of different escape mechanisms. So we also know that actually knowing the biology could be helpful in predicting response. So we know in Waldenstrom's, for example, patients that have mid-88 mutations and are CXCR wild type. So CXCR4 is another mutation that is very common in WM, and the patients that have that kind of combination are more likely to respond better to ibrutinib, whereas those that are completely wild type, so mid-88 wild type and CXCR4 wild type, have very little response. And we know that mutations also contribute to resistance to these therapies. In WM, we've sort of started to look to see whether the combination of different mutations can allow us to decide whether patients may respond better to some therapies or not. And this table is really trying to summarize the kind of the response rates across the different BTK inhibitors in Waldenstrom in WM. And I think really the take home is that patients that if tumors that are mid-88 mutated and CXCR wild type are more likely to have favorable responses to BTK inhibitors compared to those that were double mutated. The data on acalabrutinib is perhaps a little limited, and we're really just looking at data for ibrutinib and zanubrutinib. So this is what's been proposed by Steve Trion. This is in the US, whether you can basically consider treatment for WM patients based on their mutation status. So he suggests that perhaps we would profile patients with WM looking at their mid-88 and CXCR4, and those patients that are mid-88 mutated and CXCR4 wild type are more likely to benefit from a BTK inhibitor, whereas those that are wild type perhaps need to look at other options, although there's some suggestion that zanubrutinib could be helpful in this instance. So again, suggesting that maybe the mutation status of this lymphomas could in time maybe guide our selection for therapies. What about things like CAR-T and other immunotherapies? We know that we're going to start thinking about biomarkers before we select our patients rather than basically an all-comers approach. We know that patients who have pre-existing high exhausted T cells within their tumor tend to do worse with CAR-T, and this is in the setting of follicular lymphoma. And those patients that have low circulating CD8 T cells in their kind of peripheral blood at baseline, these patients also seem to do poorly. So something about not just about the tumor, so not just about the intrinsic features, but the extrinsic components of the tumors are also important for predicting responses to CAR-T therapy. And this really sort of interesting paper came out a couple of months ago where they basically said that, well, are there surrogates that we can measure just from the baseline bloods that we do for patients in clinic? So what they did basically was show that just using a simple blood draw pre-CAR-T, this is in lymphoma patients, both for indolent and for large cell lymphomas, that they can use these 14 variables to basically define what they called an inflammatory signature. And the patients that had an inflammatory signature were more likely to do worse with the CAR-T, the CD19 CAR-T. And in fact, they were able to simplify this into a 6-lab panel for things that we can routinely do in our blood work, hemoglobin, LDH, CRP, albumin, and so on, and showing that this had the ability to predict whether patients will respond to CAR-T. I think obviously these are still in its infancy. We obviously need to validate these studies, but I think what we're trying to do now is we have many of these therapies. At least in B-cell lymphoma, we have a lot more choice. How do we make sure we get the right drug to the right patient? So this is kind of how a lot of my work goes into trying to basically move our therapies into a more precision model. So we know not all patients respond to therapy, and how do we get the right drug to the right patient? I think what we do now in a lot of our clinical trials on lymphoma, we basically build in parallel ancillary studies where we basically are trying to define predictive biomarkers of both response and resistance. We're trying to basically use that information to evolve our trial designs, biobanking, also looking at sort of biology-enriched trials, and we are looking for contemporary endpoints. Most of our endpoints are based on response, and response that is defined by imaging. And can we move that, or can we use complementary tools that are biology-based, whether that's MRD or ctDNA, and use that in combination with imaging to be able to improve our contemporary endpoints? And we hope that with this sort of roadmap, we'll be able to sort of improve our getting our right drug to the right patient. So with that, I'll sort of just end by saying that I think chemotherapy, obviously the mainstay of treatment for indolent lymphomas, they're effective. So I don't think we should throw chemotherapy away. But I think that we must acknowledge now that these are perhaps blunt tools, and we also have to think about long-term sequelae. We are obviously starting to better understand the biology and what the different dependencies are. And I think that that will allow us to evolve to more targeted therapies for indolent lymphomas. And I think one of the challenges that we have, which is a good challenge, I guess, is that we actually have wider therapeutic options. And the challenge is going to become how to choose these therapies for different patients. And hopefully we think that in time, this will be driven by predictive biomarkers, and basically using these predictive biomarkers to really enrich our trials going forward into more biology-enriched clinical trials. And with that, I thank you for your attention.
Thank you very much for this very clear, comprehensive view, and also for these last slides. As you see on your left, this is the University Center for Personalized Oncology in Switzerland, and so this applies to many of the things we do. So questions for Jessica? Marcos.
Yeah, I had a question that might already been answered, but I missed it. So when studying the simple biology of lymphoma, when thinking of follicular lymphoma, I thought of constitutive activation for BCL2 expression. And my bet would have been that BCL2 inhibitors or BH3 mimetics would have worked wonderfully there, which they didn't. And in CLL, it wasn't so obvious to me. Now, my question is, why didn't it work? And is there a possibility that it still work if it comes with combinations?
Yeah, that's a great question. I think all of us were perhaps a little surprised by that. But I think that what we understand from the biology is that BCL2 translocations are very early genetic events. Now, the question is, how important is it for later in the disease? And I think that what we may find is that so monotherapy is not particularly effective, but in combination, it looks like it could be effective. And I think that what could be really helpful is that the BCL2, the tumor, the follicular lymphoma may not be so dependent on BCL2 when you've got this kind of mature tumor. However, there is a thought that that the BCL2 may be important for the kind of progenitor population, the population that may be responsible for relapses. So there may still be a role for it, but it probably needs to be explored, maybe trying to use it as maintenance therapy after you've eradicated the bulk tumor, and using it perhaps to target the residual disease. So, I mean, we were of course, the field was perhaps a bit surprised that it didn't work as well as it, but I don't think we should discard it completely.
Other questions for Jessica? Are you testing for genetic makeup in indolent lymphoma before first-line treatment? And what if, let's say, a patient had a panel done and had a P53 mutation, in follicular, how would you design first-line?
We do it for purely academic reasons, so it doesn't influence anything that we do at the moment. So I think, aside from things like mantle, where we would do it, or CLL, but most of the other indolent lymphomas, it's mostly for academic interest. It doesn't influence anything we do currently.
Okay, final opportunity. Uli.
Could you please comment on the sequencing of bispecifics and CAR-T in indolent lymphoma? We've heard in myeloma, we usually use the CAR-T very early at first, and after that there's still the opportunity. But given the more indolent behavior of most indolent lymphomas, maybe it's the other way around.
Yeah, that's a great question, and I'm trying to see if I could answer it in a very concise way. You're absolutely right. I think a lot of it is about balancing toxicities and efficacy for an indolent lymphoma. What we have seen from the data for CAR-T, at least in follicular lymphoma, that it remains sort of efficacious whether you're looking at second, third, fourth line. But we know for bispecifics that they're probably better being used earlier, because when we look at their efficacy in fourth, fifth line, they're certainly less efficacious, whereas CAR-T don't, at the moment, at least with the data that we have, doesn't seem to lose its efficacy. So there is probably a school of thought that perhaps we should be using bispecifics earlier and reserving CAR-T for later, and perhaps reserving it for the more high-risk patients with follicular lymphoma.
So I'm sure there are many more questions, but we will refer the people who want to ask questions to the apéro, which will follow just across right after. So it's a great pleasure to close this. I want to thank all the speakers. I also want to thank Silke, who organizes this very well all the time we do it. And I would ask the speakers and chairs to come down, because we want to have a little photo for the photo album at the website maybe. So thanks everyone for joining us, and join us for the apéro.